Perfect.
All right. Got it.
I hope I'm audible.
Yes, I can hear you.
All right. I think we are back in business. Excellent. Thank you. So, Dr. Alhawsawi, I think we can start the recording.
It is. It has already started, so it should have given you a message that it's recording.
All right. 8,220 people die every day. That is 5 people a minute. 5 lives lost, 5 families bereaved, children, sisters, mothers, fathers, spouses gone. This is what we call the invisible pandemic. 6 million people have died from the COVID pandemic over the last 2 years. 3 million people die from healthcare associated harm every year. We need an Operation Warp Speed for patient safety. True Error is Human was published 20 years ago, and that spawned the patient safety movement. A lot of progress has been made in the last 20 years, but not sufficient. So my colleague, Dr. Alhawsawi, and myself have embarked on a project to talk to professionals and patients around the world to get fresh insights. Our hope is that these conversations will bring patient safety into mainstream and provide new insights and solutions to achieve the vision of zero harm. Hi, my name is Dr. Abha Agrawal. I'm a physician by profession and a patient safety advocate. Our guest today is Dr. Mohit Garg. He is an emergency physician by profession, writer, musician, entrepreneur, sportsman, and a poet by passion. He's currently working as consultant and head of the Accident and Emergency Department at Glen Eagles Global Hospital in Mumbai, India. He's passionate about quality of care, patient safety, academics, and is involved in teaching activities to young doctors, nurses, and other healthcare professionals. He has over 10 years of experience working as an emergency physician, where he feels that emergency decision-making is critical in deciding the patient outcome and survival. His philosophy is to provide the right treatment to the right patient at the right time and to save a life. So Dr. Alhawsawi and I will take turns in asking starting this conversation. So first off, Dr. Mohit, can you think of a personal story, either related to you or someone you know, that will bring the human face to the patient safety discussion we are having today?
Okay, so thank you, Dr. Abha, for that wonderful introduction. Regarding this first question of yours, I did give it a lot of thought, and my medical background is from a government hospital in India. And as you're aware, government hospitals are perennially overcrowded, underfunded, and I think all the doctors and all the healthcare professionals are stretched to the limit. As part of my medical training, I do remember an incident during my internship wherein the OTs were running full and we had an elderly male patient with a gangrene of the hand. And due to the unavailability of the anesthesiologist, the 2 surgical registrars actually considered and did the amputation of the hand under local anesthesia, which was something that gives me goosebumps even now as I'm talking to you. Another incident was that while being part of a government hospital, we were prescribing medicines which were facilitated through the government, but they might not have been the right medications indicated for prescribing to the patients who were coming to the government hospital. And which I feel that these 2 incidents can be part of patient safety. And because in India, you have a sharp contrast. On one side, you have the state-of-the-art medicine being practiced by brilliant doctors with the latest technology in all the corporate hospitals. But the majority of the patient load is on the government hospitals still. So I guess such stories about deficiency in patient care and the compromise in patient safety, there'll be hundreds of them with me, in fact.
Thank you.
Thank you, Dr. Mohit. So another important area is the definition of patient safety is the absence of harm. And every specialty, has kind of different areas of harm. Every hospital has different areas, within the same region or the same countries. There are these different variations. But just to build on, that definition of absence of harm, and from your own practical experience, just to kind of build on what Dr. Agrawal mentioned, that our goal and we're asking experts like yours from different parts of the world the same questions. Our goal is to try to understand at different parts of the world if we're dealing with the same issue kind of presenting in different format, or are we dealing actually with more or less the same situation, and how is the situation from a high income setting, middle income or low income setting, whether or not this has an impact on patient safety. So just to go back to the points of the key harm areas, in your practice and from your local experience, what would be the top three areas of harm that you've seen in your experience?
Okay, so the first and foremost will definitely remain medication errors and the hospital-acquired infections. That I feel is the area of interest worldwide. Now, two things set India apart from what is different worldwide. One, I would say, is the pre-hospital care. Now, that is something that is evolving in India, but unlike the Western countries and the high-income countries, pre-hospital care is non-existent in India. And I feel that the initial management that is being done, be it a recognition of your STEMI, a stroke, stabilizing the vitals and it to the hospital, a pre-hospital notification, all these things do make a lot of difference in the overall clinical outcome of the patient. So that is one thing I feel from India's perspective is different. Secondly, to me, what I would personally feel is that India has a lot of traditional based medicine, be it the Ayurvedic, be it the homeopathic, and almost I would say 60 to 70% of patient care in India is provided by such practitioners, and they are practicing the modern medicine. So that is one aspect which I feel in patient safety that is not really highlighted. So that needs to be addressed because of lately with the new government guidelines, there's a bill which says that people who are practicing the traditional methods of medicine, they would also be allowed to practice surgical skills and surgeries which are as much as appendicitis or cholecystitis or even hernias, which and cataract surgeries, which I feel is really compromising patient care with the way the government formulation policies are. So yes, we are all aware of the various things, surgical site infections and hospital-acquired infections and audits and other things. But from an Indian perspective, I think we need to pay attention to these things wherein we should have the right qualified medical practitioners practicing medicine. And the second, I would definitely say pre-hospital care should be something that the policymakers should definitely put some efforts on.
Interesting. Now, just on the medication safety and the WHO, has decided that this World Patient Safety Day this year is going to be about medication safety and medication without harm. What would be an intervention that you would think you would want to see from an organization like the WHO, or from what would be an intervention that you want to see on the ground in India when it comes to medication safety?
See, first and foremost, I would really want a protocol-based system being incorporated into the Indian medicine. If you see the medicine practice in the US or UK or European countries for that matter, it's very much protocolized based, and you know the right medicines and the protocol that you're going to follow, unlike in India. So I think it is very important that all hospitals and nursing homes incorporate a system like that, wherein they have strict policies in terms of medications and the patient care that needs to be given for specific illnesses, I would say. And at the same time, of course, over the past many years with the accreditations and all, there have been online prescriptions and to Indian medicines, and even the doctor's treatment sheets and discharge summaries are all mentioned as per the guidelines. But I would say we are very much in the nascent stages of that. And that leads to a lot of medication errors. I am constantly doing lectures on prescription errors and other things, but still that resistance is there from the doctor's side, and even the senior doctors, I would say, at the consultant level find it difficult. People are still more comfortable with the handwritten prescriptions in India, but I definitely would say that leads to a lot of medication errors. Even the treatment charts of inpatients in the hospital is smudged and with the cancel a lot of cancellations. So I would definitely feel that from an Indian perspective, prescription errors are something that can be avoided, and all the patient safety goals that you see are preventable. So I guess this is something that we need to put a lot of effort on.
So let
Thank
me
you.
go a little deeper on that. Let's say you have the free reign for India, for where you practice. You practice in government sectors, in private, corporate, for-profit hospitals. I know some of them, resource environment as well as resource challenge environment. If you had the free reign today for a vast country like India in some way, what would be the three things you would do for medication errors?
See, first and foremost, as I said, I would come up with the proper treatment guidelines, as in if you have a UTI, what antibiotic to give, if you have an LRTI, what antibiotic to give. First and foremost, in India, there's a lot of indiscriminate use of the antibiotics. As on a lighter note, I say they have become like a welcome drink for patients. Patients also feel that if you're not given antibiotic, you've not been treated properly. So one is, I would say, indiscriminate use of the antibiotic needs to stop, because it is leading to all the superbugs coming and the things going wrong with antibiotic resistance. So that is one. I would say that you need to control the prescription of the antibiotics. Secondly, I would want a protocol-based driven healthcare. That is what I have incorporated in all the emergency departments that I have set up. There is a standard treatment policy that I have kept for all the common emergencies which come, so that that standard of care is maintained. So whether I am on duty or I have any of my junior colleagues or other doctors on duty, the treatment does not change. So this is something that I can incorporate at my department, but I would feel that this is just the tip of the iceberg, and we need to address this on a larger scale. And third thing, to avoid medication errors, I feel that all these things for patient safety should be driven at the institution level. We can definitely think of in a broader term for the country, but as I told you, there's a sharp contrast to the healthcare being provided. But if this comes and it is driven at the institution by the policymakers, by the doctors, the nurses, the technicians, I think medication error is something that can be addressed. Even if just a small thing, if the nurse refuses and tells the doctor, doctor, your prescription is not right. I want it in capital letters, in generics, with the proper dosing, in legible handwriting, with your name, signature, date, time. These small steps can make a lot of difference, I feel.
What's the penetration of CPOE, which is one of the main technologies that has been proven to reduce medication errors, along with barcode med-admin? This was CPOE has been proven to reduce medication errors since 1994, since landmark David Bates articles. So what's the penetration in India?
I would say it's not there in India, apart from very few big corporate hospitals which would be doing it. I don't think that barcode is available in many of the hospitals. Even the top corporate hospitals, only few of them would be incorporating. So definitely that system of indenting medicines and all those things are there, but ensuring that whether it's given to the right patient. So to go back, I would say very few hospitals still have those patient ID bands on their wrists. It's non-existent in the government hospital, but even in the top corporate hospital for patients coming into the emergency and daycare, very few have that band which is there, which will identify the patient.
Right.
So
You
there
use
are
CPOE? Sorry.
no, we don't.
So you use handwritten prescriptions. You are not writing prescriptions on the computer
No,
based.
not in the emergency, because the patient load is such that there is a constant flow of patients, and emergency medicine itself in India, it's a young branch, I would say. So yes, I have worked in hospitals wherein CPOE was incorporated and we used to have Indian medicines and then get it. But I would say majority of the hospitals still go with handwritten prescriptions.
Dr. Alhawsawi, if you're okay, I wanted to ask the same thing about the hospital-acquired infections, another key area that you mentioned. What would be the three things that you see are the problems, and what would you do if you had free reign to say, we should have zero CLABSIs? I'll give you an example in my own hospital where we used to have standard UTI CLABSIs, COWT and CLABSIs. We have not had a COWT for over 2 years. We went almost 565 days without a CLABSI. We had one last year in February and none again for a year. So it is achievable. That's even at the height of the COVID pandemic, yes, right? Where obviously there were many other overriding concerns. So I can say, based on my very first-hand experience, it's achievable. In this hospital, as well as I was at a level 1 trauma center, one of the largest trauma centers in Brooklyn, New York, where you have much sicker patients. Even early days in 2010 or so, we went 18 months without a CLABSI. So wow, we don't want to say that it is not doable because my patients are sick, I have trauma patients, I have multiple illnesses, etc. What are the things that you would advise professionals in a country like India or anywhere to do to prevent a single death from HAI, hospital-acquired infection?
I would really say continuous training of the staff becomes a lot important, because at the senior level, you can definitely drive through it, but ensuring that it is happening with the junior doctors, the registrars, the nursing team, the patient care attendants is something I would feel that needs to be driven, because that understanding of how important it is to avoid these hospital-acquired infection, that is still not there at the junior level is what I feel. And being consultants, being senior doctors, you cannot be at the scene, at the bedside all the time. So that is something that you need to make people aware. Now, I see that most of the hospitals I've worked with, even in these quality steering meetings that we had, wherein all this data was presented, you hardly had consultants being present for such meetings. So that is one of the challenges, and we cannot pinpoint that one doctor is not following the infection control policy. Recently, yes, we have incorporated wherein the doctors are asked not to wear a tie, a suit, a wristwatch. Now, all these things can be small steps. That is one of the things I would say. Secondly, one important thing we have to see is that in India per se, there's a lot of attrition among the nursing team. There are nurses which are traveling to the European countries, to the Middle East, and also, so you see there's a constant attrition of good trained nursing staff. So that is also, I personally feel that can lead to this, because the newer nurses who come, they need to be trained. And if you see, yes, of course, the big hospitals, all the infection control guidelines are being followed. But I would really say procedures are done in an unsterile manner in the smaller nursing homes and clinics.
So, over the past 2 years, the elephant in the room, COVID, has been top of mind.
Yes.
So what in your in your opinion, how can we make patient safety top of mind in the Indian healthcare system? For policymakers, for you talked about clinicians and mainly physicians like myself, who are not easy to kind of deal with. as well as the public, to kind of make it a top of mind. What would be, your recommendation if you were to advise the government, the policymakers, the clinicians to make it a top of mind?
First thing I would say that the government needs to invest in healthcare. For a country with a population of 1.5 billion people, close to that, you have the government spending less than 2% of the GDP on healthcare. So as part of patient safety, our focus is always on the clinical part. But provision of the infrastructure, the engineering, the equipment, the manpower, all these things are also the things which are part of patient safety. And I really feel that the government should support this financially, as well as they should help set up all these big centers of excellence, and the safety and quality has to be driven even at the government hospital. We cannot say that the onus lies only on the private hospitals for the accreditation and for taking care of the safety and all, but I feel this has to be driven even at the government hospitals, which carry the major burden of the healthcare in India. So that is something that I see, because you cannot have safety without quality. So quality is something that we need to bring up in the government hospitals, and then definitely talk about safety. But right now, the position is such in India that the hospitals are so less and the population is huge, that the quality and safety are not even on the radar of the government policymakers, I would say.
Okay.
Absolutely. Well said. I mean, we can't have two different universes, private universe and speaking of mindset and training, just want to share with you an anecdote. In 2011, I was a Fulbright scholar, and I decided to spend that time. You are given as an international Fulbright scholar 6 weeks, so I spent that at a major tertiary care teaching hospital, SGPGI in Lucknow, which is considered second to AIMS, essentially, in many ways. So I had all this high ambition and ideas about patient safety and engaging everyone. And what I realized 2 weeks later is I became the hand washing doctor. There is this doctor from US who just wants to talk about hand wash, which was a major blow to my self-esteem. I'm thinking I'm here a physician, well-trained, chief medical officer, Fulbright scholar, and I became the hand wash doctor, essentially. But what I was surprised to hear from you is that more than 10 years have passed since then. And we are still at the same place where people need training and reminder about HAI and hand washing. So that gives us some pause. Shifting gears a little bit, you mentioned about pre-hospital care, engagement of families. I think both Dr. Alhawsawi and I are convinced and persuaded that we need to engage patients and families in promoting patient safety. It's considered the patients are considered the most underutilized resource in healthcare. And also, if we think about it, they have the most to gain or lose if there is healthcare associated harm. It's their lives that are at stake. So, how can we, even in spite of the challenges of professionals' engagement in India, in a complex, multi-layered, heterogeneous country like India, understand all the challenges? How can we start to engage, rather, I would say, patients and families in co-production of care so that they are partners in ensuring safety? Some thoughts on that?
Yes, that is a very good aspect that you have touched. And I would say that it is really very important to involve the patients and the relatives to drive patient safety. Now, a few initiatives that can be taken is one, that the patient should be made aware of what patient safety is. Everybody just expects to heal quickly and get rid of the disease and move out of the hospital, but they do not know what patient safety is. So at the time of admission, I think it is important to inform the patient what patient safety is, what are their rights, what are their responsibilities. That is one. Secondly, during the hospital stay, I guess regular feedback, one-on-one feedback with patient That can also help get a feedback how safe they feel in the hospital. Then third, involving patient in the treatment. For a patient who is scheduled for a surgery, have a patient mark the site of surgery themselves. These can be small initiatives that I would feel wherein the patient also feels involved, and this can lead to less mishaps. There should be some sort of a data registry, which could be web-based or cloud-based, wherein patients can give their feedback directly to the nodal authorities. Right now, I feel that the number of adverse events, they go underreported. Hardly there would be reported and it just goes down to a clinical audit of the internal hospital committee. So I think there has to be some mechanism wherein patients or their relatives can also report such adverse events happening in the hospital, which can highlight patient safety. So these were a few things I felt that patient can be involved because it is very important to educate the patient about patient safety. At the same time, you can have NGOs being involved. You can spread the message of patient safety at a community level. So you see, all the publications and all the studies, we tend to focus on the clinical aspects, the medications, the treatment. But I feel even the meetings of the clinicians, they are less based on quality and patient safety. And I would like to appreciate you, Dr. Abha and Dr. Alhawsawi, for taking these initiatives at a global scale. So I would definitely want more involvement of the community to understand how important patient safety is.
Perfect. You mentioned earlier that you want to see more investment from the government in the healthcare system. Now, to stay on the financial aspect, and I always say that if you want to grab the attention of policymakers, talk about money. So talking about money, money does not just influence policymakers; it influences also providers and clinicians, etc. So, how do you see financial levers being used to either improve or not quality and patient safety? And I'll just give you a prospect of some people, and there is concern that a model such a fee for service would actually result in just doing more and not necessarily doing more of a high quality or even appropriate care. And lately there's been this discussion about value-based healthcare at different levels, and it's being pushed through the some of the multinational platforms like the G20. So do you believe that financial interventions and the way that we compensate providers would have an impact on quality and patient safety? And if that's the case, how from your perspective, what would be the intervention that would see works in India, in the Indian context?
Okay, so here I would like to bring out some startling facts. In fact, so when Dr. Abha told me about a meeting like this, I said I'm not going to be all the good things. So you have to talk about the other things also in Indian healthcare. Now you see, majority of the patients these days they all have healthcare insurance, but in India I would say there's a lot of healthcare fraud also going on. So I have worked in government hospitals and corporate hospitals in the city, and in big corporate hospitals in tier 2 cities. And just for a few example, I would say that I was near a tier 2 town, tier 2, tier 3 town, and you would have a person just mentioning their first name on their insurance card and only the name of the village. And all the family members near about that age would utilize that same insurance card to claim insurance. Now that is one aspect of it. You, in the smaller nursing homes, you have people submitting their insurance policies and getting claims, and part of that commission goes to the hospital or the nursing homes also. Now, these are healthcare insurance frauds, I would say, and they are quite rampant in India. That is one aspect. Now, even coming to the bigger hospitals in big cities. So, what happens is patients have pre-existing illnesses. They are on medications for years. But just so that patient's claim is passed, we doctors do tend to not mention the past illnesses, not mention the duration of their illnesses, because people don't want us to mention that on their papers, because there's a chance that their insurance claim might get rejected, and if it is declared on their document, then in the next policy, their premium amount goes higher. So these are the other aspects of the healthcare sector, which not many people openly talk about. So, and free services, I don't think in a country like India would ever work, because people tend to misuse the system.
So are you in favor of, for example, co-payments and payment for performance? Are you in favor of fee for service when it comes to do you see those working
No,
at all?
definitely, I'm not in favor of free for service. The co-payment is definitely a good option, but people should pay for the healthcare that they should get. So there should be no compromise on patient care and patient safety. Now, as I told you in the beginning of the talk, that if I'm at a government hospital, you can't expect me to prescribe and write down the medicines which are available in the government pharmacy just because I'm giving it free to the patient. Because as a doctor, my ethics and my conscience is telling me this is not the right thing I'm doing. So I don't think that free for service is a model that should be promoted anyway. Definitely, you can have subsidy provided by the government, but definitely the government needs to pump in more money financially to raise the bar of the care of patients. Care.
Okay. Dr. Agrawal?
So speaking of the Indian context, you mentioned a few things about, insurance frauds being rampant. Maybe I wanted to bring up another thing that is quite troubling to me as I hear more specifically about the Indian context. There seems to be a crisis of trust between patients and physicians.
Yes.
And sometimes that leads to, violence and lack of safety for healthcare professionals. And that seems to have made a major impact. Even in my own family, somebody goes for a procedure, or somebody goes to get an advice for a procedure, and whatever the physician says, they have no trust whether it is being done for real need or not. And
Right.
Same way, physicians have no trust that the patients are not going to, families are not going to turn toward violence. So there's a bit of a crisis of trust. How does that play into patient safety and decision making at the point of care, where the rubber hits the road?
See what this has led to over the past many years. If you see, ever since healthcare came into the Consumer Protection Act, the patients have become consumers, and that has really affected the doctor-patient relationship. So, and there are sporadic incidents of violence against doctors. And what this has led to is that, suppose I have a small nursing home. So instead of having a mob at my door, I would rather not, I would rather choose to not treat a critical patient or somebody with a life-threatening emergency, knowing that if this patient gets admitted to my nursing home and if something happens, God forbid, to this patient, then probably there will be violence, there will be vandalization. So what that has done is that even the good doctors, they think of referring the patient to a bigger government hospital or to a bigger corporate hospital. But that time, that crucial golden hour, I would say probably is lost, which compromises on patient safety. Another few things that I would like to highlight what is happening in India is that there's a lot of healthcare awards which have cropped up. Okay, so
Even once a week, you pay
yes,
X $1,000 and you get an award.
yes,
right?
you get an award, and that is being published in the newspapers, in the magazines, on websites, and that tends to misguide people. There's a law on social media these days. You have a lot of promotion for scarless surgeries, for painless surgeries, and they'll send you a car to pick you up from your house. Now, all these things are there to misguide the patients. And I would definitely say that this trend that has started of online reviews and things being pushed by websites, the reviews about doctors and all, these are compromising patient safety, patient quality, and these will have long-term repercussions in the years to come. At the same time, in India, what is happening is there are accreditation bodies and smaller nursing homes, the hospitals, of course, they are going for it. But if you see the accreditation at the time of accreditation, few months prior to that, the hospitals and the nursing homes will start working to ensure there are no non-compliances. But the remainder of the month, which from the major part of the year, you will see that there will be less focus on the quality and it will be all brushing with the broom under the carpet. So data is manipulated, it is fabricated. And of course, it is difficult for the accreditation bodies to monitor that. They can lay down the policies, they can lay down the guidelines, but to have a constant vigil over it, I think it will be difficult for them. So in the Indian context, if you see all these things, there's a whole spectrum of things that we can definitely talk about. Coming to the doctor-patient relationship, yes, I have written a lot of articles. Every time I see images of a doctor's bloody face or something like that, it really is heart-wrenching. And I do tend to write about that, and it's getting really bad. And that is why what is other things happening is that a lot of doctors do not want to get into this profession now. See, if you look at the bigger picture, they don't want their kids to pursue medicine. They want to go abroad. And you have this brain drain from India as well, looking at all these things which are happening with the healthcare system. So it's not just the patient safety. I feel it is important to address the safety of the healthcare professionals also.
So I like to end on a positive note. With all the challenges and problems, which there are plenty in every context, right? Indian context, US context, global context. Talk to us, how are we going to save lives? If you were to ask, a policymaker, global patient safety experts in the world, a burning question and some solutions from your perspective, from the bedside, that this is what I would do so that I can save lives.
So I think it would be very important to involve the clinicians on a regular basis to talk about patient safety. And that is really important because the policymakers are there, but the ground reality would be something very different. So I think on a global scale, from all the countries, we should have from all the states, like it all percolates like a spoke and wheel model, wherein all the aspects that we want to address come out from the clinicians themselves. So as I told you, we have to strengthen at the ground level. We have to strengthen individual hospitals, nursing homes, take the inputs, give it to the state committee, from the state committee to the national committee, from the national committee at a global level. So I would say that we need to address this so that this issue of patient safety and patient care percolates all the way down till the tier 2, tier 3 nursing homes and hospitals also. So that I think that is the way forward. And this initiative is one of them, to involve people from different continents to come up with what the ground reality is in their nation and to bring it up to everyone.
Maybe the very last question, because that also we need to ask you, is about reporting. You can't improve what you can't measure. So one, and this is across all healthcare systems, but we're interested to hear from an Indian healthcare system context. How do you see the reporting systems of adverse events, be it manual or electronic? What if you were to kind of pick a number, a percentage of healthcare facilities that are doing reporting, and also, is there any learning platform, at any hospital or a network of hospitals that you're aware of, or a region or a national level?
So I would definitely say that most of the adverse events are underreported in the country. Because if a hospital brings it forward, they can feel that the employees are blamed, people can become defensive, and that tends to affect the working ability of the hospital. And plus, I don't think it is reported. Even if you see on the hospital websites and all, they do not report such things. So majority of the adverse events, I definitely feel they are at, and most of the hospitals, I would say 99% of the hospitals do tend to underreport the events which are happening. Like,
But is there a mechanism in place? So underreporting is a big problem, you know, across, as you said, for the reasons you mentioned. But is there a mechanism in place for reporting, but people are just not reporting, or are there many hospitals that don't even have the reporting?
So there are mechanisms in place at a hospital level. Definitely, all the hospitals. I can talk about the corporate hospitals because we do have regular meetings, which are the quality meetings and the infection control committee meetings. So there are all these data which is being captured, but that is not there at the government level, I feel. So regular meetings just to ensure that they meet the criteria for the accreditation body, that is happening. But I am really doubtful whether that data is particularly properly input or not.
Okay.
Great. Well, Dr. Mohit, thank you so much for taking the time today to talk to us. I have a feeling we have a lot more to talk about. I'm intrigued with your idea about how do we get patient safety into everyone's consciousness.
Right.
At every level, right? Hundreds of thousands of physicians, hundreds of thousands of nurses, and other, hospital administrators to CEOs. I'd love to talk to you later. How are we going to do that? Because I agree with you. Without that, there's no improving patient safety. So with that, thank you so much. And all the best to you in your career.
Thank you so much. And it was wonderful interacting with the both of you.
Thank you very much.
Have a nice day.